Hi, everyone. This is Melissa Widener. In this chapter, chapter 7, we're going to talk about disease occurrence and morbidity and mortality. So at the core of epidemiology is epidemiologists are trying to understand disease patterns, the distribution of illness, otherwise known as morbidity, and death, otherwise known as mortality. Also affecting those are the determinants of illness, again, which is morbidity, and death, which is the mortality within a population. Epidemiological tools consist of counts, rates, ratios, and proportions of diseases or illnesses related to person, place, or time. Epidemiological data can be gathered through healthcare records, vital statistics reports, disease entries, some at the state and some at the national level, health assessments, and surveys. Population surveillance is an important epidemiological tool to facilitate the identification and monitoring of the health and any changes to that population. It serves as an early alert system to identify public health issues, informs the effectiveness of disease prevention and control measures, guides public health policy. Surveillance should have a specific goal and reliable methods. Surveillance is an ongoing systematic collection, analysis, and interpretation of health-related data essential to the planning, implementation, and evaluation of public health practices. It provides information to policymakers it provides information to guide public health officials, policymakers, healthcare providers, and the public in general. There are 4 types of surveillance. Active surveillance is when you identify every case in a systematic manner, and that requires a significant amount of human and financial resources. Passive surveillance is information provided by healthcare providers and systems, but that is often inconsistent, but it does require less financial and human resources. Hybrid is a combination of active and passive surveillance, and sentinel is surveillance conducted by one or a small number of healthcare facilities. Types of surveillance methods include community-based, population-based, aggregate, case-based, clinical, laboratory or confirmed, zoonotic, serosurveillance, and adverse events. And you can read through the different kinds of what they mean. But there are different kinds of methods, some which are just identified in the community and some are identified through laboratory sources. And last but not least, we have the adverse events, which is the unintended consequences from healthcare or medical treatments. This is another way to look at the surveillance methods, but you can see they happen at different levels. Some of them happen at the institution or healthcare provider level. Some of them are local, state, national, and then international, which happens through the World Health Organization. So it is kind of an exponentially growing group of surveillance that happens. So case identification, so if we're going to surveil things, then we have to know how to identify it. And case identification it generally consists of the clinical signs and symptoms, laboratory findings, confirmatory data, and contact or exposure information along with a time period. There are 3 essential components that include the person, place, or time, and it can be modified over time. Think back to when COVID-19 first presented itself. There were some clinical presentation that we knew were consistent with COVID-19. For instance, we all think of like the loss of taste and the shortness of breath. But over time, as we got to the next variant, you didn't have as much shortness of breath, your symptoms weren't as intense, and some people didn't lose their taste but still had COVID-19. And also think to the point back to the pandemic when we weren't even able to test people for COVID-19. It was more based on symptoms. So that definition can be evolving as time over time and how things change. COVID-19, I'm going to refer to that a lot during our epidemiological case and class, just because we lived through the pandemic. So I think it makes some of this easier to define and see. Some people got very frustrated as well that these case definition changes happened. But again, we didn't know anything about this disease when it started. And then as we learned more about it, our data and case definitions improved. The other example that's in your book on page 75 talks about the case definition of measles and how that started and how that changed as well. So you can check that out. There are three types of case definitions. The first one is suspected. That is where someone has signs and symptoms of a condition, but they're not exactly definitive enough to point to one condition or another. Probable is when someone has signs or symptoms of a condition with some type of epidemiological link, such as an exposure to someone with the condition. So again, think back to before we could confirm COVID. If we knew someone had COVID and we were around them and we probably got it, that would be a probable case definition if you had the signs and symptoms. And then as our technology improved, if you developed signs and symptoms of a condition and you had an epidemiological link and a positive diagnostic test, you had a confirmed case of a disease. You can see how they kind of build on each other. So once we have a case, we need to look at if there is an outbreak investigation. And this is a multi-layer process that includes inductive and deductive reasoning to determine things about the outbreak investigation. And some of the first things we're going to look at are the affected disease population or the population at risk. We're going to determine the disease spread. We're going to look at the agent that caused it or the reservoir where it lives. We're going to characterize the relationship between the host, the agent, and the environment. And we're going to determine the preventative or treatment measures to limit mortality and morbidity. And I kind of like this slide because it kind of reminds us, we've lived through the COVID-19 pandemic, so it becomes much to our forefront and we're more familiar with that. But it's certainly not the first pandemic or outbreak that we have experienced in the United States. There's been smallpox, the Spanish flu, measles, death, and the other recent one is Ebola. So it is certainly something we've learned about over time. And in fact, some of those principles we learned from the pandemics 100 years ago stayed true to the pandemic that we recently overcame in our early days before we had limited information on how to handle it. Once there is an outbreak, we're going to look for an outbreak. We're going to conduct an outbreak investigation. And the first thing we're going to do is the preparation. If the disease is known, you're going to research the signs and symptoms, the clinical presentation, the causative agent, what you can do to screen and diagnose the disease, the mode of transportation, the natural history of it, the incubation period, the case definitions, and the control measures. So again, not to keep talking about that, but the first thing we're going to do is talk about the outbreak establishment and surveillance. So remember when we first started hearing about COVID-19, we all heard of Wuhan, China because they noticed a change in the pattern of the health of those people, and they all had similar signs and symptoms. So first thing we're going to do is establish if there is an outbreak, and then we're going to define how we're going to define the case. We're going to calculate the attack rates and determine the distribution of the cases according to person, place, or time. And we're going to develop surveillance strategies to investigate contacts. Then we're going to formulate a case definition. So again, remember how we talked about how the case definition can change if we don't know the disease over time. Then we're going to verify the diagnosis, and that can be done with screening or diagnostic tests. And if there is a known screening or diagnostic test, those cases will be confirmed. Surveillance, again, continues to identify cases and watch the characteristics of the outbreak. When we look at the characteristics of the outbreak, we're going to use descriptive epidemiology to, again, talk about person, place, or time. We're going to characterize the characteristics of the cases, how the disease changes, and the difference in the disease based on the frequency of the location. For instance, that's how they found a new variant of COVID-19, because the first variant was all acting the same. And then when they noticed that people were having different signs and symptoms, that's when they started to look for the new variant. We're also going to look at personal information, signs and symptoms, related exposures. Epidemiologists will construct epidemiological curves, and they will also look for the potential source of the outbreak. In hypothesis development, they will develop, again, a hypothesis about what they know about the condition, the possible etiology, and mode of transmission of the disease. When epidemiologists evaluate the hypothesis, they will conduct an analytical epidemiological report, either cohort or case study, to confirm, either deny what they found. Do they know where the disease started? Do they know how it spreads? Anything related to that disease, or define it. Once they can do that, they will implement control measures or preventative measures to prevent further disease outbreaks. And then finally, once these have confirmed, and again, this is likely fluid and develops over time, they will write a report of the outbreak investigation. So there are different levels of disease occurrence. When a disease is endemic, that is the level of disease within a population at one time. Most people will say now that COVID is endemic. There isn't a sudden rise or drop in it. It just is there. Hyperendemic is when it occurs at different levels within the community, but rarely with no specific pattern. Epidemic is when there is a sudden rise in the cases of a disease within a population over the endemic levels. You may see an outbreak of the disease or a cluster develop somewhere specifically. A pandemic, which is what we are just recovering from, is an epidemic that has spread over several countries and continents and affects a large number of people at the same time. And a synergemic is when there are two or more epidemics happening simultaneously. When I think of this, I think of this past winter, how in the fall we had the rise of flu, RSV, and COVID-19, and it was like the perfect trifecta of what was happening. It wasn't declared an epidemic, but it certainly led to a rise in hospitalizations and disease, and certainly caused epidemiologists and healthcare providers to take a second look. When we have disease occurrence, we want to explore the who, when, and where. So we look at the demographic information used to characterize the people with the disease. This can be where they live, their age, their sex, their race, anything that defines a population. And when is the time period of the disease. We may notice that diseases come with the season. If we think of the flu, we know that it's more common from uh, October through the early spring. And the other thing we want to think about is where it is, and that's the geographic location. Now we're going to talk a little bit about morbidity. Morbidity is simply the rate of disease within a population. And it can be defined primarily in two different ways. The first way is the incidence rate, and the incidence rate is the number of new cases occurring within a specific time frame in a population at risk for a disease. So, for example, the total population at risk for a disease is 5,000 in 2023, and there are 500 new cases of the disease in 2023, and the multiplier is 1,000. And you will see sometimes that multiplier can change. Sometimes you'll see it as 1,000, sometimes you'll see it as 100,000. It really is just variable on the amount of people that you're trying to make the incidence rate for. In this case, I'm sorry about that. In this case, we're going to use 1,000. So the incidence rate is the number of new cases divided by the population at risk times 1,000. So the incidence rate for that example is there is 100 per 1,000 persons. So there's 100 people that get sick out of 1,000. Remember, incidence rates are only the new cases and can be specific based on different demographics. So when we're looking at the disease rate, another way to describe it is prevalence. And the prevalence rate is the number of persons in a population within a specific time period affected with the disease or condition. And this includes both new and old cases. The prevalence rate gives a picture of the disease in a population and provides information for long-term resource planning. It also serves as a measure of disease burden of a population. Prevalence rate can be impacted by the incidence rate, mortality rate, and cure rate. Prevalence is also affected by the duration of an illness. If there is a small amount of new cases but a low cure rate, and the disease has a long chronic period, the prevalence rate will increase over time. And I like this little graphic here so you could remember the difference between prevalence rate versus incidence rate. I thought it was a good way to show the difference. So where do we get our data? And for morbidity rates, these can be primary sources or secondary sources. There are disease registries. There are communicable diseases that you need to be notified. There are some that are national, and there are some that are statewide. For instance, gonorrhea and syphilis are ones that have to be reported in the state of Pennsylvania. Healthcare facilities generate data. There's occupational data such as absentee records, educational data. Again, absentee records is one of them. Contact tracing data, military records. There are morbidity surveys, both at the national, regional, and local level. And another source is insurance data. And what they use there is the hospital insurance plans. Medicare and Medicaid collect this information, long-term disability, and accidental insurance. The R naught, it's called, is a value that is calculated that represents the average number of individuals that a single infected person can be expected to transmit the infection to. That is the symbol that it is represented by, and the R naught is essential because it provides information to understanding the potential of an infected person to spread the disease within a population. It is sometimes referred to as the average spreadability of an infection or the reproduction number. If an R naught is less than 1, each existing infected individual can transmit the infection to less than 1 new individual. The disease is likely to decline and eventually dissipate. If the R naught equals 1, each existing affected individual can transmit the infection to one other individual. With the R naught of 1, the disease is likely to remain stable for a while and will most likely not produce an outbreak or an epidemic. If the R naught is greater than 1, each existing infected individual can transmit the infection to one or more individuals. For example, if it is 3, it indicates that each person could infect up to 3 other individuals. The R naught characterizes the intensity of the infectious disease to cause an outbreak or an epidemic. Mortality gives the rate of death of a population. It provides information about the different causes, associated risk factors, demographics, geographical differences in death that occur by disease. This is an example. The infant mortality rate is something that we often hear, and this is what we call a specific mortality rate. Specific mortality rates can vary by age, sex, race, disease, or any population identifying variable. So when we look at the infant mortality rate, it's the number of deaths in infants less than a year old in a specific time frame over the number of live births during that specific time frame times 1,000. The crude mortality rate provides a measure of the entire population. They often use the mid-year population for the number because it changes over the course of the year. So in a crude mortality rate, you take the number of deaths from all causes in a year over the number of individuals in a population at mid-year times 100,000. And you're usually talking about larger numbers of people, so we'd use 100,000 as your multiplier. The case fatality rate is expressed as a percentage of all cases. A case is defined as someone who has died from the disease. It differs from the mortality rate in the denominator. Case fatality rate is the number of individuals with a specific disease during a specific time period. And in a mortality rate, the denominator is the number of people at risk of dying from a specific disease. And again, because it's expressed as a percentage, it's multiplied by 100. Mortality data comes primarily from death certificates. The problem is that sometimes these certificates are not accurate. The contributing factors may not align. The timeframes of the onset of the disease is sometimes unknown, and sometimes there's information that is missing. I know when I work as a hospitalist, I know that patient for a very brief period of time, and I may not be able to fill in all the background information. Deaths are coded according to the underlying cause of the disease, the injury or event that initiated the chain of events that led directly or indirectly to one's death. So, thank you for listening.